Hello and welcome to this edition of Bayou Time. I'm your host, Keith Weisheit, licensed clinical social worker with Terrebonne Home Care. Very glad you are joining us. We have a very special show for you today. I'm excited about that because as we approach October, October is a very special month. In my mind, October is always Pink Month, and here's why. Every 2 minutes, a woman is diagnosed with breast cancer in the United States. And October here is Breast Cancer Awareness Month. We are so very excited to be joined by Dr. Jeffrey Rao, the plastic surgeon at Rao Plastic Surgery and at Terrebonne General. Mary Bird Perkins Cancer Center works regularly with breast cancer patients in the community. Dr. Rao performs breast reconstruction surgery after breast cancer patients have completed their treatment. And we're so very excited to have you, Dr. Rao. Thanks for joining us today.
Thank you, Keith. I'm glad to be here.
We appreciate it. And listen, we can't think about you as Dr. Jeffrey Rao without thinking about the legacy that the Raos have been in this community for so many years. And I know it's one of those things that you take pride in the legacy of what the Raos have meant to so many of us, personally, professionally, through the hospital, and just what the Raos are for this community.
Absolutely. I'm proud to be, included in that group. And, I have a lot of family members, and you always say it's contagious in the family, but we just like helping people overall, and we've had good mentors, my dad and my uncles, and just taught us well how to treat people, how to care about people, and just be real with them.
And I love that perspective. The other thing that's really important is that the family, as far as I know it, have always involved themselves and been connected to Terrebonne General Medical Center and now Terrebonne General Health System. Let's talk a little bit about your role there.
Yeah, so at Rao Plastic Surgery and at Mary Bird Perkins, I'm involved a lot with reconstruction in general, and the predominant cancer that I'm involved with is breast cancer.
Mm-hmm.
There's all types of other things around the body that I'll get involved with, but by far the most common is breast cancer. So I'm involved. I see patients at Mary Bird Perkins,
Mm-hmm.
and new cancer patients and all other sorts of patients, but the most of them are cancer patients. And we discuss and treat every different type of problem that they have.
Wow. And so what was it about plastics? What was it about plastic surgery that had that draw? As we know, I know a lot of your family have been in general surgery, but let's talk about why that specialty of plastics.
I've always been the artsy, picky one in the family.
Okay.
It's just my nature. It drives a lot of my family nuts when I can't let something go. I'm like, let me fix that. And I've been doing it all my life, so
Okay.
it's innate. I have a lot of creative hobbies,
Mm-hmm.
and so it fell right in line. I like people, and I
Right.
like taking care of people, and I like being creative and coming up with neat ways to approach things. So I don't have a routine. I'm proud to say that. I come in and I look at each person and I just flow with what comes out of my brain. It makes me a little inefficient, but it's natural and it's real, and it keeps me on my toes, kind of.
Wow, it sounds like going into plastic surgery just fit into who you are as an individual. And that's nice. You bring that person into being that physician.
Yeah, certainly. I mean, I enjoy it. There's not a day I go into work where I see something I've always seen. A lot of people can say that about various professions, but I definitely, every day, I can pick several things out and go, that was an interesting day.
Wow.
Little subtle things that I
Right.
notice. But yes, it's very challenging, it's very rewarding, and I enjoy it. So.
Well, October is a very special month. We think about October and pink, but for people with screening, when should women get screened for breast cancer?
So the typical screening for a while has been at 40, annual screening at 40, and you should also do physical exam to see if you feel any suspicious nodules. But it's been getting younger and younger. I've seen a lot of women that are, in their 30s, 20s even, that have breast cancer. So higher risk people do get screened a little earlier, around
Okay.
35, and there's some other varying things that if I'm doing a non-cancer breast surgery, I'll have them screened earlier just as a baseline.
Okay. And so, like you mentioned, some of those things is if there's a family history, that typically is one of those big factors, right? One of those risk factors that we say, be very, very specific, be very prudent about your self-breast exams.
Absolutely.
So that, especially if there's a family history of that.
Correct. And most cancer is not associated with any kind of family history. So it's you don't want to feel like I don't have anybody in my family and you can just relax. So that's an important point. But also, if there is genetics that are connected to breast cancer, that you should have your breast removed before at an early age. It's called a BRCA.
Okay.
gene test.
Right.
That's more rare, but it's still something that you should be cognizant of. And if you have multiple family members, you need to talk to your doctor about it.
And just have that conversation, just
Correct.
open that conversation.
Correct.
Speaking of the conversation about Mary Bird, and I know your work with Terrible in general, but let's talk about the breast cancer program and maybe some of the specifics of it.
Yeah, so the program involves a comprehensive program. It involves multiple specialties. It starts with the primary care doctor, and then it goes all the way through the general surgeon, the pathologist, the radiologist, the oncologist, radiation oncologist, myself. It's just a lot of us together.
Right.
We come together to treat the cancer as a whole, and we meet every week at a tumor conference to
Right.
discuss these patients specifically.
Right.
Because each patient has a unique situation. So that's very important, and we are proud to say we offer the most advanced treatment for breast cancer right here in Houma.
Wow. And it's so very unique. I know, I don't want to give it away, but on Thursdays, that lunch is very important to be able to look at, like you said, some of those unique cases. And it's great to have multiple specialties really kind of giving their input. And so as we close, it's exciting to know that you have that. And so we're talking a lot about your role and your various roles and the different things that you did. But let's talk a little bit about what point in a woman's cancer journey, as you talked about all of these different disciplines, when do they end up seeing you? When do you come into the picture, if you will?
Right. So most of the time I see active breast cancer patients, and they'll come from the general surgeon. They'll do, or the OBGYN when they're doing the screening mammograms, or primary care doctor, and they'll have a biopsy. And then they'll have a plan that they discuss with their general surgeon and what route they want to go. And typically the surgeon, I know all the surgeons here, and they just call me directly most of the time. Hey, I have this new patient, and we talk about it. We don't just put you in a conveyor. You are a person. So we get on the phone and we talk to each other about what's going on. And I part the C's. Whatever's going on in my schedule, I make room to see you as soon as I can. And we have a very long discussion and go through all the details. But I can also see a lot of patients at various other stages.
Okay.
There's some patients who have the gene positive BRCA gene or some other genetics that we don't know about. They just have a high incidence of having cancer in their family. I can talk with them about possibilities of reconstruction after mastectomy, and also patients that have already had mastectomies and weren't offered or didn't have the means or whatever was going on in their lives, they couldn't have reconstruction previously. I meet with those, and those are called delayed reconstruction patients.
Wow. And I love the fact that you lead right into my next thought,
Yeah.
which is how does that breast reconstruction work after that mastectomy? Because I got to tell you, that seems to be such an important part of both the physical and the psychological aspect of dealing with cancer.
Great question. Yeah, I tell every patient, they come in with a concern that am I being vain? I have a lot of children and people worried about me. Am I going through more surgery? And it is the wrong way to look at it, I tell them, because what makes you a woman is your physical appearance. And to truly beat cancer for the long term, you need to wake up every day and not see scars that show you that say, hey, I'm a breast cancer patient. We'd like you to wake up and say, I beat breast cancer. In fact, I look better, and you don't even think about yourself as a breast cancer survivor or breast cancer patient. So it's a lot about the long-term victory over cancer. It's very important.
Talking about history and how that matters. We had a program over at Terrible General and Mary Bird Perkins. It was called Look Good, Feel Better. And that program is exactly what you're talking about. When they look good, they feel better. They don't look at themselves as cancer or cancer patient. They look at themselves as a person, as a woman.
Right.
It's so very important.
It is very important. I mean, it's not about, when everybody thinks about plastic surgery, you think about your brain goes to Hollywood and all these overly done people. It's not what that's all about. Most people that have plastic surgery, and especially reconstructive surgery, it's about developing confidence in yourself, and what makes you a woman, and feeling good about it. So that's the real thing. That's the thing that we harp on big time in the consultation.
Yeah. Are there any other advantages to that breast reconstruction?
Breast reconstruction, overall, it provides an extra tissue support, an extra means of just having more than filling out your own ultimate looks down the road. I mean, breast reconstruction really just completes the whole picture. you're not, sitting there and wondering, am I going to look or feel the same one day? It's just completing the whole process to make you feel like I came out of it and I'm better for it.
Wow. And so, speaking of that, are there some different techniques that are used for the different needs that people have? Like you said, everybody's kind of individualized for you.
Right, and there's so many different situations, but in general, we there's two main types of breast reconstruction. You either use implants or you use the patient's own tissue,
Okay.
and that's the two main categories. And there's a lot of dependent factors depending upon which way we go. And each side has their positives and negatives, but overall, we try to favor the patient's own tissue
Sure.
for a lot of reasons that benefit the patient.
More natural.
More natural.
The body
Correct.
accepts it. There's not
Correct.
risk of kind of rejection, those kinds of things,
Correct.
foreign bodies. But sometimes it's necessary, right?
Right, and we say it's a more involved surgery. It's a longer surgery. You stay in the hospital longer, but the reward is much greater. Like anything in life, it's a short, lived few-day hospital stay.
Right.
To get your optimal outcome to do what we call breast flaps.
Right. Gotcha. The flap, which involves their own tissue.
Right, their own tissue.
Okay. And so, how should a woman prepare for having one of these surgeries? What should they be thinking about?
So you need to generally think about just preparing your life. It's about a 2 to 4 week recovery process, and preparing for kids, for rides, for various things. You'll have drains and maintenance and things of that sort. It comes and goes, in no time, but the main reconstructive process after our first big surgery to either put implants or the flaps in is the most important part. And you have a lot going on. It's very confusing. You have your cancer you're worrying about and the reconstructive process, but we help walk you through it, and we want you to just be present, and we'll take care of everything for you.
And again, I talk about it so very often. I'm so very honored that over the years, more than 10 years, been able to be the person kind of doing that support group and helping them people. And I will tell you, being present is the greatest value. And that's what people often need to hear about being present. We're glad that you're present for them. We're glad that you're present for us. We're talking a little bit about these different surgeries and how the women can prepare for it, but also the surgery itself and the different type of tissue that is being done with that. Let's talk a little bit about that surgery itself or the recovery, because they're a little different, right?
Right. So we have the implant side, which is using breast implant, which is made of silicone, and we'll often have to use a piece of cadaver tissue, which forms like an internal bra to hold the implant in place.
Okay.
That's a great surgery. It's the most common that's done, in the world. Because it requires less skill and it's less recovery for the patient. You don't have to use a donor site, which is all great stuff,
Right.
Overall. But on the other side, if you have the option of having flaps, hands down, I am a big advocate for it. I feel like that's the better long-term result. It's your own tissue. You don't have to use any foreign material. There's less complications. And the most common flap that we use is called the DIEP flap, and it stands for DIEP, named for the blood vessel that supplies the belly tissue.
Okay.
So the belly tissue is the most common area where women, would rather get rid of tissue, so it works
Sure.
out well. So you have that tissue removed, and we use a microscope. And myself with a colleague, Dr. Mark Stalder, that comes from LSU. We train together, and he trains residents doing the surgery. We come together because it's a two-surgeon situation to get it done in a reasonable amount of time.
Right.
And we both work together to microscopically sew vessels that are as big as spaghetti strings into blood vessels that are in your chest. So the tissue gets moved from here. Part of the rib gets removed, and we expose the internal mammary vessels, and we sew those blood vessels in. So the tissue that was down on the belly typically, and we also sometimes use thigh tissue,
Right.
it gets moved up here, and it's living up here. And then after that, we then tighten up the belly tissue or the thigh tissue. And, the recovery after the flap surgery, you are in the hospital for 3 or 4 days. But don't base a short-term discomfort off of a long-term better result.
Right.
Because once those flaps are healthy and living and doing well, which we do very well with it, and we're very particular and we're very strict on every little thing involving this flap.
Right.
Once it does well, you're in a wonderful situation because you don't have any foreign material. Your body loves you, so
Right.
moving your own tissue someplace else
Right.
is a much better option. And then for either route that you go, you're going to have to do a second surgery several months down the road. But that surgery is much easier. It's outpatient. It's just a touch-up surgery to help fine-tune things.
Right.
So in general, implant, tissue, both got their positives and negatives. Flaps are favorable. They are a little bit longer surgery, more hospital stay, but and a little bit longer recovery because you got a tummy area to heal, you got a thigh area to heal. But in the long run, you'll be done. You know, implants can have its problems down the
Right.
road.
Right. As we've seen.
Several patients need revision surgeries.
Right.
So that's why it's preferred. It's much more natural. You're done with the reconstructive process more so than if you go on the implant route.
Wow. And it's much more vascular than I assumed.
Oh yeah.
And so that's just one of those things. I'm a guy, don't really
Yeah.
think about it, right?
Yeah.
Not a physician, but it's just, there's a lot of vascular involvement, and that's important. And that maybe it takes a little while longer for that as well, for the recovery.
Absolutely, and it's very it's a lot of finesse involved. It's
Mm-hmm.
the most intense surgery that I'm involved in because you have to be so patient for several hours,
Right.
and you have to be under the microscope and carefully dissect out these blood vessels. But the result is big, and it's wonderful to see how wonderful the patients can look.
I love it. I love it. The other good thing is that you mentioned it early on, that you spend quite a bit of time initially in that first consultation. What is it like, and how do you work with the patients to ensure that they really understand the procedure and the outcome? Because you've been very eloquent about describing these two options here. I would expect you do that a lot with the patients
Absolutely, I do a lot of drawings. I go whatever their situation presents, I take their specific situation, and I then branch off from there and show them these are your options. This is what we're going to do, And sometimes they do have options, sometimes they don't. Like we need to go this way,
Right.
And that sort of thing. So I help them work through that, at least probably on average an hour or longer, and then I say this is a lot. Let it digest. Go home.
Let's sink
think about it. When we sit back down later and go back through it again for patients to help comb through details with family members and what have you, because yes, it can be very hard to understand for people in our own profession sometimes,
Sure.
so it's tough to understand. So the patients, I'm trying to help them get the point. And I always say, just like you go to a mechanic and drop your car off, you're not worried about the radiator, whatever's ticking, as long as you're not a mechanic or don't know how to work on cars. It's like, just tell me your symptoms, tell me what's going on, we'll fix it. Just relax, and we'll take care of everything else.
Very good. I know the navigators are often very involved in what you're doing, the patient navigators. Can you talk a little bit about the support there?
Oh yeah,
Bird?
there's a lot of good support at Terrebonne General. There's the nurse navigator kind of takes charge and makes sure that each patient's being handed off to each specialty, and everything's going in a timely fashion. Because sometimes you need this study done before we can make this. It's a lot of little details, so the
Right.
navigator helps with that.
Right.
There's also a nutritionist. There's all kind of other programs that are involved at Terrebonne General, like the You Thrive physical fitness
Right.
program, then the survivorship program. So I see my patients for a very long time, for years, to make sure that everything's still settling into exactly what we need it to be. So there's a lot of hands involved to make sure that you get your
care
treatment
you need.
completed.
Dr. Rao, we can't thank you enough for coming on, sharing with us all these important things. And if people have questions, we want them to reach out to you. And so available at your practice, both of those. So thanks again for joining us.
Thank you. I'm happy to be here.
All right. And that will do it for this particular segment of Bayou Time. Don't go anywhere. A lot more programming here on HTV.